No. So thank you very much, Professor Mills, for the kind introduction. Dear Professor Nickel, dear Professor Mills, dear colleagues and friends, my name is Pedro Lopez Ayala. I'm a clinical research fellow at the Cardiovascular Research Institute Basel, and it's my great pleasure to be here today in this wonderful city and to have a face-to-face meeting. So I would really like to thank the organizers for making it possible and for the hard work for it. So in the next 7 minutes, I will present our common work entitled Novel Criteria for the Observed Zone of the ESD01-hour high-sensitivity cardiac troponin T algorithm. So before starting, just one quick question. How many of you or of your institutions are using the ESD01-hour algorithm or are planning to do so? So please raise your hands in case. Okay, perfect. So I hope that the following presentation will help to clarify some concerns regarding the observed zone. So the ESD01-hour algorithm has a class 1 recommendation in the latest ESD NSTEMI guidelines. It has shown a very high safety for early rule-out, a high accuracy for ruling of NSTEMI, and a definite triage in about 70 to 75% of patients. But what about those patients being triaged to the observed zone? Well, the latest ESD NSTEMI guidelines recommend a 3-hour high-sensitivity cardiac troponin determination in these patients. However, no specific cutoff for further triage is recommended. Now, recently in 2018, a 0-3-hour troponin T absolute change of 7 nanograms per liter was proposed. And last year, we showed the performance of this cutoff, which showed a very low safety for rule-out of NSTEMI. Nick Mills was also chairperson, so probably he will remember. So therefore, our aim was to derive and validate a novel 3-hour pathway for the observed zone of the ESD01-hour high-sensitivity cardiac troponin T algorithm. So for this endeavor, we used the APACE cohort. APACE is a multi-center international diagnostic study in which adult patients presenting to the emergency department with chest pain are recruited. Serial blood sampling is obtained, and final diagnostic adjudication is performed by 2 independent cardiologists using the 4th universal definition of myocardial infarction and using all medical records, cardiac imaging, troponin values, and 90 days follow-up. Safety was assessed as the sensitivity and negative predictive value of ruling out index NSTEMI, while accuracy as the specificity and positive predictive value of ruling in index NSTEMI. For externally validating our novel criteria for the observed zone, we used the TRAPID-AMI cohort, which is an independent prospective international multi-center study which recruited patients in 12 centers on 3 continents. So very briefly, regarding the derivation and internal validation of this algorithm, of this novel criteria, we used a Bootstrap validation approach. And very briefly, we developed the algorithm using the entire original sample, so the sample of APACE, using all patients. For developing the algorithm, we predefined performance targets of 99% above 99% for sensitivity and negative predictive value. We tested multiple troponin T cutoffs. We selected an optimal combination, and we determined the apparent performance. Now, for the internal validation, we used a Bootstrap technique, which is a resampling technique, and we generated a Bootstrap sample by sampling individuals with replacement from the original sample. We developed the algorithm in the Bootstrap sample, applying the same developing methods as in step 1, so step A, B, and C. Then we determine the apparent performance of this Bootstrap algorithm in the Bootstrap sample, as well as in the original sample. And then, in order to calculate the optimism, the difference between the Bootstrap performance and the original performance was obtained. This was repeated 1,000 times. An average optimism was obtained, and we subtracted this optimism from the apparent performance obtained in step 1 to obtain an optimism-corrected estimate performance, so to say the internal validation. So going on to the results, a total of 2,076 patients had 0, 1, and 3-hour troponin T values. The application of the EST01-hour algorithm showed a very high safety for rule-out and a high accuracy for rule-in, and a total of 27% of patients remained in the observed zone. The optimal combination of a 3-hour single value and a 0.3-hour absolute change was a 3-hour value less than 15 nanograms per liter and a 0.3-hour absolute change less than 4 nanograms per liter, allowing a very high safety for rule-out, and sensitivity and negative predictive value were above 99%, and only 1 patient was missed. For rule-in, a 0.3-hour absolute change above or equal than 6 nanograms per liter allowed a very high accuracy with a positive predictive value above 85%. The Bootstrap internal validation showed very similar findings to the apparent performance, both for rule-out and for rule-in, and a total of 62 patients, when applying this novel criteria on top of the EST01-hour algorithm, were ruled out. 21% of patients ruled in, and importantly, there was a 35% relative reduction in the observed zone, and even more important, a 50% relative reduction in end-STEMIs in the observed zone. External validation in the TRAPID-AMI cohort showed very similar findings, both for the EST01-hour algorithm as well as for the novel criteria for the observed zone. Again, we achieved a 40% relative reduction in the observed zone and a 50% relative reduction in end-STEMIs. So, as any other study, this study merits some limitations. We conducted it in 80 patients, therefore we cannot comment on the performance in other clinical settings. We cannot generalize our findings to patients with terminal kidney failure requiring dialysis, as these patients were not included, as well as late presenters defined as a chest pain onset and maximum above 12 hours. So, dear chairpersons, dear colleagues and friends, to summarize, a novel derived pathway combining a 3-hour high-sensitivity cardiac troponin T concentration less than 15 nanograms per liter and a 0.3-hour absolute change less than 4 nanograms per liter allowed a very safe rule-out of end-STEMI in patients remaining in the observed zone of the EST01-hour algorithm. Full study results are now available in circulation, and thank you very much for your attention, and I will be happy to receive any questions.
Super presentation. Any questions from the floor? While you're thinking, Pedro, congratulations on a really important, I think, addition to the work that your group's done on this pathway. It always felt like a little missing question, what to do in the observed zone. I guess the question I have is what went wrong with the prior attempt? I mean, you started this process by looking at an algorithm that had been developed in another institution, and your findings were quite striking. So can you just comment on what went wrong with the prior attempts to do this, and why you think your approach was better?
Thank you very much for your question. If I needed to summarize it in 2 words, I would say sample size. So the study of 2018 that I mentioned in the background in the introduction, they had a total of, or let's say, if I remember correctly, 120 patients in the observed zone, and the number of end-STEMIs in total was 11, which is a 2%. So with 11 STEMIs, it's difficult, and obviously. You can maybe reach 7 nanograms per liter for rule-out because maybe these patients, the 0.3-hour absolute change was 8, 10, 20 with only 11 patients. That's one main thing. Also, they just shown apparent performance, which also has overfitting, no internal validation, and also the troponin that they used for the final adjudication, it was a conventional troponin T assay. It was not a high sensitivity troponin T, and therefore probably missing some myocardial functions.
Very diplomatic response. If I'm allowed one last question, so what do we do after following your algorithm if they still end up without a decision at 3 hours. What's your approach in clinical practice to these patients? How do you decide what to do next?
I mean, probably we also need to know the limitation of troponin, and probably in these patients, serial sampling at 6 or 12 hours is probably not the. I mean, it's possible, obviously, but we also need to take into account imaging, non-invasive imaging, and if I'm not wrong, your group just published a paper in Circulation, if I remember, or in JAC, sorry, using troponin to guide if CT angiography is needed or not. So probably CT angiography in these patients is an interesting option.
Super. Thanks. Okay, we will try and keep on schedule. So.
Yeah.